I believe it's my honor again to introduce Professor Neuhaus. And this time with a topic which is, the first part is quite familiar to me, biodegradable stenting, but I got stuck in the esophagus, but some people were braver and they went to the pancreatic indications. So I'm curious.
Yes. Yeah, I would like to report on a relatively new type of stent. It's biodegradable and it can be used for the pancreatic duct, but also for the bile duct. It's available with 3 degradation profiles, so within 12 days, 20 days, and 11 weeks. And it has a very special shape with a helical bile channels, as you can see on the outer surface. So this promises that drainage is not only achieved through the stent, but also as a kind of a wick alongside the stent. It comes with different diameters, lengths, and it has, of course, the potential to eliminate stent removal drainage. And I would like to show you 2 cases. First one, 77 years old male patient, admitted with painless jaundice, bilirubin 21 milligram per deciliter, CT scan, EOS, stenosis of the distal CBD, upstream biliary dilatation, no pancreatic tumor, no mets, so suspicious for distal common bile duct cholangiocarcinoma. And even if surgery is still an option and will be, or it was finally be done, this patient, this is an indication for preoperative drainage because of this high bilirubin. And in addition, we added tissue acquisition. So I failed to cannulate the common bile duct. So I had an unattended access to the pancreatic duct. And without continuing with recannulation of the CBD, I left the guide wire in the pancreatic duct and do a transpancreatic sphincterotomy, so a small cut of the common channel in the direction of 11 o'clock. And then, of course, and this is also part of the ESGE guidelines, we have to protect the pancreas with a pancreatic stent, and this is now this biodegradable stent, which a short degradation profile, so it will disappear within the next 12 days. And the aim is now, firstly, we block the pancreatic orifice. Secondly, we straighten the usually S-shaped formation of the distal part of the bile duct or of the common channel. And therefore, I now try to really cannulate in the direction of the CBD at 11 o'clock. So I carefully pushing the wire forward, a hydrophilic wire. Of course, I do not inject because this will easily create an edema. At least I do not inject at this stage. Wire cannulation first. But now we have some resistance, so I have to enlarge the upper part to have more space and a better visualization of the CBD. So to cut the fold gives a better vision of the papillary roof. And then we recannulate again. And the case was quite difficult. As you can see now, I couldn't advance the wire, but I'm obviously in the duct. And at this stage, we inject a little bit contrast and to see the anatomy. And you see a tight stricture very close to the papilla. And now under fluoroscopic guidance, we can manipulate the tip of the angulated wire and of the sphincterotome to get it into the direction of the stenosis. So the wire is rotated, and now we are in the CBD. We don't have to opacify the intrahepatic biliary system because we had the MRI, so we know there is only stenosis at the site of the papilla, so probably a cholangiocarcinoma very close to the papilla, or a very tight stricture. So we leave the wire in place, and then we insert now, okay, this is now tissue acquisition with a brush. And subsequently, we place another biodegradable biliary stent. Because the patient will be scheduled for surgery within the next 2 weeks. So with a mid-term degradation. So, and it's the pushability is very good. So we can pass without dilatation of the stricture. We can easily pass the narrowing with a stent. So no stent removal is needed before or after surgery. And the next case, a 68-year-old medical doctor who was referred after recurrent attacks of acute pancreatitis, no comorbidities, no biliary disease, little alcohol consumption. MRCP shows a pancreas divisum with no signs for chronic pancreatitis. So this patient was scheduled for ESCP with EST of the minor papilla, which is located, as you can see, at 11 o'clock. This is the major papilla. And I use a tapered catheter with 4 French tip and a 018 hydrophilic wire. Try to identify the pancreatic orifice towards the Santorini duct. This can be facilitated by secretine injection and stimulation, but unfortunately secretine is no longer available, at least not in Europe. So we carefully push a wire forward. It's now obviously in the duct, but in the wrong direction. So this is suspicious of positioning in a side branch. And at this stage, I insert the catheter a little bit more and opacify to see the direction of the Santorini duct and of the main pancreatic duct. To pull the wire back from the side branch and advancing the wire forward, now changing to a 035 wire. And we cut in the direction of 10 o'clock and 11 o'clock. This is the direction towards the Santorini duct. We completely split until you see the inner lumen of the Santorini. And these patients should be protected with a pancreatic stent. I think this is a good indication also for biodegradable stent because no further follow-up is needed. So there's a publication from Refugees Group, 38 consecutive patients, single-center prospective pilot study on patients with biliary and pancreatic indications with excellent results. Only one adverse event, mild BEP, and rate of premature migration was quite low, and degradation worked well. As you can see, complete 100% at second follow-up. So very promising, and I would like to conclude. There is a variety of indications in patients with biliary or pancreatic obstruction. Selection should be done depending on the degradation profile based on underlying diseases. For fast degradation, prophylactic pancreatic stenting as shown, incomplete ductal clearance after removal of stones, sphincterotomy, medium bile leaks, perioperative biliary drainage, residual stones, and slow maybe in benign biliary pancreatic stenosis. So it's a technically easy implantation, improved flow, theoretically at least, due to the helical design. Stent migration is rare, extraction not required. Potentially costs can be saved, and the patient compliance can be improved because there's no need for stent extraction.
Thanks for this very clear presentation. I do have two short questions, however. The first is, of course, about the money. Are they about the price range of other plastic endoprotheses?
No, they are much more expensive.
Okay.
So far.
And the other
but
is
theoretically, you can save money because you don't need further follow-up investigations.
No.
Huh? But of course, this has to be calculated in a cost-effective model.
Yeah, and you also, who gets the cost? I mean, on which budget? That's also always a problem within the hospitals. But okay, I think you gave a clear answer. And the other is, what about getting strictures? I did not see the length of follow-up in this paper from Ray Pitchy, if you got strictures on the longer run.
Yeah, we need a longer follow-up, but at least his study showed that at the second follow-up, at least you didn't see any more parts of the radiopack material. So obviously it's completely disintegrated.
For example, in the first patient you demonstrated that went for surgery. Are you looking at the surgical specimen if there are signs for chemical reaction, as we have seen with esophageal biodegradable stents?
Not yet, but this would be an interesting, I think, study. Yeah.
Thank you.